I'm happy to give you this talk on electrochemotherapy in liver tumor. These are my disclosures. Well, we know already that local ablative therapies in the liver are improving progression-free survival, as, for example, in colorectal liver metastases up to 11-fold, and are able to improve also overall survival up to 4 times after 8 years and compared to systemic therapy alone. Further, we have the evidence that compared to the last decades, local ablative therapies performed percutaneously are not anymore inferior to open surgically performed local ablations and achieved the same local tumor controls than local ablations performed with open surgery. Well, a new kid on the block in the armamentarium of local ablative therapies is the electrochemotherapy. Electrochemotherapy is not a thermal ablation, but a chemoablation that uses a systemically applied chemotherapeutic drug, mostly bleomycin or cisplatin, where the efficacy of this drug is locally improved by electroporation. This way, the local cytotoxicity is significantly increased. In ECT, we have 3 antitumoral effects. First, the death of the mitotic tumor cells. Second, the tumor cell ischemia. And third, the stimulation of the immune response. ECT has some advantages for liver tumors. It causes only a minimal damage on neighboring tissues. That means it's preserving collagenous structures. Therefore, it's applicable in the proximity of critical structures like portal veins or hepatic veins, central bile ducts, or in the vicinity of the diaphragm. Further, it is suitable for large and non-spheric lesions, is tissue sparing, and it's repeatable. As ECT is a chemoablation and not a thermal ablation technique, it is insensitive to heat sink effects in the vicinity of large vessels. The low dose of the non or poorly permeant chemotherapeutic drug that is required for the efficacy of ECT means that we have no systemic side effects of the chemotherapeutic drug per se. The chemotherapeutic substrate of ECT is mostly bleomycin, alternatively cisplatin. Bleomycin is a hydrophilic, slow to non-permeant drug that has a huge molecular structure that is not able to enter into the tumor cells to pass the tumor cell membrane. Therefore, we need a kind of Trojan horse, the electroporation, to bring the bleomycin into the tumor cells. The hardware required for the electrochemotherapy is on the one hand generator for the electroporation and electrodes. We have freehand electrodes for the liver tumors with different needle length, sizes, and different active tips. What is mandatory for the efficacy of electroporation is the full coverage of the tumor, an optimal spacing of the electrodes between each other, And parallelity, what we have to maintain to achieve an appropriate current discharge in the tumor tissue. Optimal opportunity to increase the precision of the ECT treatment is the use of a stereotactic navigation system like cascadation to be able to have an optimal coverage of the tumor to achieve a security margin that's mandatory to achieve an optimal local tumor control, and to have also the spacing what is required to achieve an optimal local ablation result. Further, with the new segmentation software, we are also able to maintain and to preserve the critical structures in the vicinity of the ablation zone and not to penetrate, for example, the major bile ducts or portal veins. For the electroporation, a general anesthesia, it's required because the electric pulses might be not uncomfortable for the patients. We run the first single-center study on the efficacy of percutaneous electrochemotherapy in primary and secondary liver tumors and assess the local tumor control and the impact on the overall survival. We could demonstrate that we had an objective response rate of 85.7%. The mean progression-free survival was 9 months and the mean overall survival was 11.3 months. Interestingly, the effectiveness of the ECT was independent of the location of the lesion in terms of if it was distant, close, or adjacent to vital structures defined as challenging location. And the progression-free survival and overall survival were independent of the primary histology considered. We had only mild to moderate side effects after ECT. In a second study from our center, we compared the long-term efficacy in terms of local tumor control of different ablation technologies in primary and secondary liver malignancies. It was interesting to realize that ECT achieved the second best local tumor control at 12 months in primary and secondary liver malignancies after radiofrequency ablation and better than cryo interstitial brachytherapy and microwave ablation. It was also interesting that the largest tumors were treated with ECT. 95% of the lesions had a volume more than or bigger than 20 cc, and more than 90% of the lesions were located in challenging locations. That means in the immediate vicinity of critical structures. This is an example of a ECT in the liver dome where we treated CCC effectively. The images you see on the right side are the immediate local tumor control after 48 hours, and on the right side after 6 weeks. I want to drive your attention on the RESPECT registry. It's a TIRSA-sponsored registry on the efficacy of percutaneous ECT in primary and secondary liver malignancies. It's a single-arm, prospective, observational, multi-center study. The patient population consists primary and secondary liver malignancies treated with percutaneous ECT using the IgA clinic generator. The patient enrollment phase is from January 23 to January 26. 6 is correct, and we targeted to include 250 participants. Summing up, ECT has many advantages and indications. It is no thermal ablation. It is able to preserve collagenous structures. Bleomycin has a high toxicity regardless of the histology. ECT is repeatable and well tolerated and can be used additively in between cytotoxic cycles. It can be used in larger targets and in the vicinity of vulnerable structures, in entities with low radiation sensitivity, and in locations where pain after thermal ablation is inevitable. ECT is not only the new kid on the block, it is a gap filler and might become also a game changer in interventional oncology. Thank you very much for your attention.